A continuar con nuestro programa. A continuación, el doctor John Marini, que ustedes bien conocen, él es profesor de medicina de la Universidad de Minnesota, de Minneapolis, Minnesota. Perdón. Sí, de la Universidad de Minneapolis, Minnesota, y es un reconocido investigador de fisiología aplicada en la medicina crítica. Es autor de diversos libros y artículos en la materia. El doctor nos va a platicar sobre las causas y remedio del síndrome de cuidados intensivos. Y nuevamente, si hay alguna duda, a través de esta página nos pueden hacer llegar sus preguntas. Si hay tiempo, las analizaremos aquí en vivo. Si no, por favor, les pedimos que lo hagan directamente con el doctor Marini. Bueno, nada más por atención a los demás, les pedimos que pongan su celular en modo silencioso y nuevamente la entrada el día sábado es únicamente a través de Arenal. Dr. Marini, please. Wow. The laser. Back.
Muchas gracias. I first want to say how much I appreciate being here again in Mexico City. Elsie and I have been here many times, have many friends, and always enjoy the warm hospitality of your beautiful country and people. I'm going to be speaking about improving the quality of life after the intensive care unit. And I'm going to emphasize that in order to improve, we are going to need to learn more about dynamic physiology. I'll try to keep it relatively simple. I'll define the problems, talk about the causes, talking about tested measures that might help, and then some future possibilities for progress in this area. Now, as we sit here today, we're healthy, and our bodies are maintaining homeostasis in the green part of this diagram. In severe critical illness, we are pushed into a zone where our body does not know what to do. In fact, it may be doing the wrong things. And it's that we need to correct and bring it back to a state of homeostasis. We do very well when we rescue patients. We've learned a lot in the last 30 to 40 years. But after we have salvaged the patient's life, they're often left disabled. The after effects of critical illness on the quality of life diminish for the immediate period and for as long as 3 to 5 years after an episode of critical care, or ARDS. Why does this happen? The post-intensive care syndrome is now very popular to talk about, and it's thought to have basically 4 domains: physical, psychosocial, functional, and cognitive. Now, the post-intensive care syndrome degrades the quality of life for the patient, that's for sure. But also remember, the family is severely affected by such lingering problems after the hospitalization. This is an incredibly important piece, and I'll finalize by saying something about that. Now, in terms of these domains of cognitive impairment, mental impairment, physical impairment, there are risk factors that we think we understand. Delirium, anxiety, pain, hypoxemia, hypoglycemia, hyperglycemia, pre-existing disease, prolonged mechanical ventilation, sedation, which has gotten a lot of attention, and diseases that cause inflammation, like sepsis, ARDS, multi-organ failure, and then, of course, immobility, neuromuscular blockade, and drugs. These are the things that we do to the patient. So what are the causes of the post-intensive care syndrome? I don't think we know them completely. In fact, I would argue that we know very little about what causes it. Let's talk about these interlinked causes of the syndrome. Now we're not talking about the domains, we're talking about what can cause those problems in those domains. For example, the physical. If we've learned anything over the years, it's that in the intensive care unit, we are doing too much of almost everything for too long a period of time. And we have learned that when we take away the body's challenges, such as with the mechanical ventilation and paralysis, the atrophic changes to muscle, diaphragm, etc., start to occur very early. It's been said from this famous paper in 2008 by Levine in the New England Journal of Medicine that it may be as quick as 18 hours of total rest of the diaphragm starts to cause degradation of the elements of the diaphragm. Now, when we think about physical deterioration, I mentioned before that inflammatory cytokines are an important piece, but so are bed rest and malnutrition. When we put someone in this kind of unnatural environment, the ICU environment, the ICU bed, we are doing something very different from normal life, which is quite varied, and there are positional changes with day-to-day life. There are many challenges and orientations that happen during life that don't happen in the intensive care unit. And I'll try to explain to that as I go on. Sustained bed rest does many things beside taking away muscle strength. It does decrease muscle protein synthesis and cause muscle atrophy and reduce muscle mass, decrease strength and exercise capacity. Connective tissue shortens and contractures are encouraged in bed rest. Decreased bone density, pressure ulcers, atelectasis and inflammation, and erosion of vascular reflexes and control. When we take away gravitational stresses and the day-to-day rises and falls of heart rate and blood pressure, we are modifying the natural system. We've become pretty good at reversing atelectasis, for example, or avoiding pressure ulcers. But some of these other things remain unaddressed. In the future, and in fact in the present, there are modifications for the second stage of intensive care, which recognize that gravitational forces are important in day-to-day life and must be preserved to some degree. not only for muscle strength, but also for the vascular system, which I think is something that most doctors are not really attentive to. Yes, we have very clever ways of making people exercise at the bedside. This is very good. It makes perfect sense. But unfortunately, when you look at a randomized trial of intensive physical therapy for patients with acute respiratory failure, there are very disappointing results. Basically, we think we know what to do, but we really don't know the best way to do it. I mentioned here nutritional supports, and Paul Wishmeyer has given me this slide. We often take very simple approaches to nutrition. Let's do trophic feedings for the first part, and then full feedings and calorics in the second part. But it's much more complicated than that. The underlying physiology requires adjustments of calories and protein and possibly even hormones and drugs at different phases when there's the body's overreaction and then the sinking down period and then the building up period. They require different nutritional supports. We also know from the work that he and many others are doing that critical illness restricts the diversity and alters the character of the gut microbiome. Instead of having a diverse, healthy population, in most patients it becomes very restricted, and the nature of those organisms, primary organisms, changes spectrum. So fewer and different. And the microbiome, as many of you are aware, is a focus of attention for the products generated in the gut may be influencing the body over time. So I think we have to become better at preserving the natural microbiome and also giving nutritional support that makes sense for the phase of illness. I'm going to spend much of my time on cognitive and psychosocial factors. I mentioned that the PICS syndrome has many different pieces, and this is possibly the most important. The neuropsychiatric components of the PICS include cognitive impairment, understanding, and mental impairment, such as PTSD, depression, anxiety. Cognitive, you can't think well. Memory, concentration, attention, and executive decision-making functions are attenuated. Let's go back to this environment we put our patients in. I call it the rack because it's something that has been referred to in torture. Somebody who's isolated from all normal stimuli. They have a loss of voluntary control. They are deprived of normal sensing cues. There's monotony to what they see, what they hear, and what they experience in the ICU, except for the times when they're experiencing new pain or have to go to an operation, something totally foreign to them. Monotony, and I'll come back to that. And disconnection from everything that means something to the person, such as their family. Now, delirium has gotten much attention, and of course there are predisposing factors such as age and dementia, pre-existing, but there's also incident factors, meaning related to the intensive care unit experience, the toxic, the metabolic, and brain lesions that often go along with the inflammation of intensive care. And then we layer on top of it treatments which are not necessarily good for the patient. They are directed at specific problems that we identify, but they may not be good for the patient. Is delirium really caused by the disease, the environment, sleep disruption, our therapy, or all of those? And I think possibly the answer is the last, all of them. One of the big unexplored areas in critical care medicine, at least, is the brain to organ crosstalk. The brain obviously is controlling all of our organs, our vital organs, and is receiving messages, sensory messages from the organs that modifies the brain's behavior. In a situation such as sepsis or ARDS, there are inflammatory mediators generated in the organs but affect the brain. And neural signals, neural pathway signals, are traveling back and forth between the brain and the organs. This has been shown in very rudimentary fashion about ischemia and inflammation-associated brain dysfunction and sepsis. Sepsis, one of the most common diseases we treat. The brain does undergo changes. Another thing, of course, is our sedation. Delirium is thought to be a partial product of the drugs that we use. This famous paper now 8 years ago from Denmark showed that in their experience, delirium was much less common if the patients received no sedation versus the usual type of sedation for mechanical ventilation even. I'm going quickly here, but I think some of these concepts are familiar to you. The duration of delirium experienced in the intensive care unit and in the hospital predicts the long-term impairment of cognition that's experienced by the patient after they return home. So making sure delirium does not happen or that it's reversed quickly should be one of our priorities. And I have to applaud Wes Ely and his colleagues at Vanderbilt, my former university, for what they've put together as a bundle of things that we can do to help prevent delirium and to mobilize the patient. Interestingly enough, it's not just older people that have this sustained delirium, but it occurs in all age groups coming to the intensive care unit, young people as well as old people, meaning that there's something that's happening in the intensive care unit that's affecting everyone, maybe to different degrees, but it's affecting everyone. Now I'm going to switch gears a little bit and talk about the rhythms of everyday life and how they're reversed by putting somebody on the rack and imposing what we do to rescue them and try to bring them back to health. Biorhythms are normal and they are normally in balance, and autocorrections for homeostasis, for example, to preserve homeostasis are routine and unconscious. It's been shown that critical illness and treatment disrupt the normal physiology, the rhythms, and adaptive homeostasis. That green circle that I put on the first slide or two is adaptive homeostasis. We can move within that circle and bring it back to where we should be. But in critical illness, all that falls apart. We think that light, cycles of light and darkness, are important to synchronize the circadian rhythms, the daily rhythms. We get sleepy at 11 o'clock in the evening, and we feel more alert after our first cup of coffee in the morning. But some of that is diurnal variation. We think that's only the brain, but it's not just the brain. If we try to change the diurnal rhythms of the ICU patient just by changing light, we still don't know how to do that. How much light, what intensity, what rhythm do we impose and release the light? In fact, it doesn't work very well, as was shown in this paper in The Lancet in 2016. Just changing light does not restore diurnal rhythms. Physical activity, auditory cues, and gravitational stresses may help in this diurnal coordination. Here's what happens to some of the neuroendocrine hormones in the setting of critical illness. Instead of showing a lot of variation, it is attenuated in the critically ill. Grete van den Berghe from Belgium has shown that very nicely. And most organ systems normally have a brain-influenced circadian rhythm. It may not be perfectly obvious, but many organs have activity levels that vary with the diurnal rhythm of everyday life. Critical illness alters the amplitude and the variability, a key word, variability, of neuroendocrine hormones. During the acute phase of illness, everything is intensified. But in the more chronic state of illness, it is attenuated. So again, we have to be sensitive to the stages of critical care in order to address some of the physiology that will influence the PICS syndrome. Psychosocial, family. We have come up with some interventions to speed recovery and improve quality of life in the intensive care unit. Commonly implemented are these. Unproven measures are these. Physical, gravitational stresses, mobility, physical rehabilitation. Cognitive, delirium avoidance, better sleep, diurnal variation. Emotional, family presence, psychotropic therapies. Unproven measures, probiotics about the gut, music, melatonin, light treatment, ICU diaries, adaptive stress, conditioning, minimized pharmacotherapy, and tailored nutrition. All of these make sense. They're still unproven. We've learned that despite our best intentions, and for many years it was never any pain for the patient or discomfort, or what we perceive as discomfort in our intubated patients. We had the best of intentions, but we think it was not such a good thing. Our well-intentioned response, in fact, may not be a good idea. It may push not necessarily our cardiorespiratory system, but our mental system over the edge. Monotony, and this is something I want to emphasize to you. Again, we try to stabilize an unstable situation in the beginning, but that same monotony of routines and drugs and constant infusions, etc., is probably not good for the patient. In fact, I think it is a good short-term treatment, but it has a time-dependent value. Remember, there are bidirectional signals. The feedback to the brain may actually train the brain, which can be done, of course, by studying or activities of various types that improve your mental function. But no, when we make monotony the rule, it's maybe a toxic trainer of the brain, restricting its access to new thoughts, new ideas, connections, executive function. This is one of these core principles of neuroscience, that there's an ongoing competition between nerve proliferation, nerve pruning, cutting channels, and functional pruning, meaning use this channel or don't use that channel and train the brain to do a certain task. These are constantly ongoing no matter what we try to do to prevent it. And as I speak as an old man here, a key lesson of life is use it or lose it. And I think that happens to the brain too. If we impose monotony, we are losing flexibility and adaptability. Our deprivation of orienting cues of normal life may cause cognitive decline. Not because we want it to, but because we're not sensitive to the underlying dynamic situation that is influencing our patients. If you look at the activity of the brain of a depressed patient and a non-depressed patient, the mental focus is very different, and the pruning of neural pathways is quite evident, the functional pruning. In the setting of depression, people focus on the same monotonous ideas rather than staying flexible and excitable and ready to adapt. Variety is the spice of life. We've always said that, right? We know that. We don't want to do the same thing over and over again. I believe, now this is totally unproven, that once we are within the circle of physiologic homeostasis, we want to bring the patient back from monotony toward variation in their activities. In fact, this is quite interesting, and you may be aware of this. One of the most severe punishments you can give a prisoner is put them in solitary isolation with no sensory information coming in, monotony of everyday life. If you close your eyes right now, beside going to sleep, what you will find your brain wandering. It may stay on focus for a short time, but it then wanders. Delirium is lack of attention. That's how we define delirium, right? This is one of the key features. Delirium may be our natural state when we're deprived of life's ordinary orienting cues. And in fact, there's therapies related to isolation chambers to negate what the patient's chaotic thoughts are, or organized thoughts are, and make them chaotic so that they have some chance of recovering a normal way of thinking. I think we need to encourage the familiar variations of everyday life. Could virtual reality influence brain activity and be of help here? Now, as physicians, we are enchanted by new devices and gadgets, but as an experienced physician, I'm very hesitant to embrace new technologies. But virtual reality is going to develop, artificial intelligence is going to develop, and it's already been shown very convincingly in many studies that when you put someone in a virtual reality environment by these goggles, they experience less pain. They are distracted, and pain is less sensed. You need less drug, less coaxing, you need to distract them. And virtual reality can be very distracting. Here's a woman who is doing a procedure on this patient while he's playing a video game in the intensive care unit. I think in Mexico City you have a very good institute that's exploring things like this, and I applaud you for that because I think that's really innovative. Now, this is something I haven't seen in the literature, and I'm wondering if this could be my final message to you. When we are deprived of not only physical cues and variability, but family and our social cues, we tend to get problems with our mood and our thinking. We are now at a point with electronic communications that streaming of information continuously is possible. You all know that. If we streamed information from the patient's home environment or familiar environments to them, at least periodically through the day, it might be the next step in delirium prevention and cognitive rehabilitation. We already know that rehabilitation by reorienting the patient to the real world by simulation, by artificial simulation, is helpful. Could it be that if we stream information from the family to the patient at low cost, that could be a help? So there are many ways to address delirium and the post-intensive care syndrome. We're learning more and more. The key characteristics of health are variation, homeostatic adjustments called allostasis, diurnal biorhythms, and adaptability. In critical illness, rigidity and monotony, important in the first phase, but later not a good thing. So our interventions to speed recovery and improve quality of life post-ICU may involve in the future real-world variation and training. I advocate a three-stage approach to critical care that we focus on the dynamic physiology, the rescue phase, the adaptation phase, and the restorative phase. For me, the physiologic foundation underpins everything, including personalization in the real sense and optimization of our results. So with that, I'd like to thank you for your attention, ask you to rest and recover. Thank you.